Welcome to our school of dentistry seminar. So today we have Professor Murray Thomson from Otago. You all know Murray very well. Be very short about him. He's totally one of the most prominent researchers in oral epidemiology and health service research. And he's expert on the dry mouth, and he's very sorry, yeah, and his research interests cover a wide range of dental oral health fields, and he has also provided many years of service as editor-in-chief for international scientific journals. And Murray has been awarded 2 IDEA Distinguished Scientist Award, so it's a very rare feat. And this year has been one of the new fellows selected to the Academy of Royal Society of New Zealand. So congratulations to Murray. And his talk today addressed one of the hottest topic in the oral health and aging. So it's over to you, Murray.
Thank you, Locke. Welcome, everybody. I can see by the names and some of the faces that I can see that there's a lot of fellow travelers there, so nice to see you all. Very cool. Okay, I'm going to share my screen so you don't have to look at me. And there we go. Is that working? Can you see my first slide there?
Yes.
Yep. And has it now changed?
Yes.
Yep, good, good. So we're in slideshow view. Excellent. Always pays to check. So when Locke asked me to give you a talk, I thought, what can I talk about? And then I realized that it wasn't long before, after the invitation, that I was hitting retirement age. So I'm now officially a pensioner, but I haven't retired from the university yet, but I have just under a year to go. So things are counting down, and that's quite nice to have the finish line. Excuse me. But I thought I'd talk about getting old and some of the ways in which we think about it and interpret data on aging and data on old people in particular, and some of the things that we need to think about when we're doing that, because particularly in my role as editor of gerodontology, I see a lot of papers come in where people have, I won't say misinterpreted their data, but overinterpreted their data. And, you know, it's important when we're dealing with vulnerable older people that we're actually making the right decisions, and those decisions need to be based on sound science, if you like. So what I'm going to talk about is the pace of aging. We have some wonderful and really interesting data from the Dunedin Multidisciplinary Health and Development Study about the pace of aging. And we'll look at that and think about what it means for us as we age. I'll then look at a couple of issues in interpreting data on older people. Excuse me, and the need to be cautious in interpreting our findings. And I'll use two examples. The main one I'll concentrate on is the notion that tooth loss leads somehow to cognitive decline. And then I'll also have a look at some cross-cultural comparisons, just to illustrate the issues and the things we need to think about. I love this quote here from David Bowie. the late, great David Bowie. I think aging is an extraordinary process whereby you become the person you always should have been. And I think that speaks to how, as we get older, we hopefully attain a degree of maturity and insight into ourselves and our place in the world, and our capabilities, what we can do and what we can't do. My wife would tell you that it takes longer for some of us than for others. So thinking about the pace of aging, we published a paper from the Dunedin study last year. No, when was it? Year before, on the pace of aging in our Dunedin study members. So let's just have a look at this. If we think about aging and health, chronologically, we're all getting older at the same age, at the same pace. You know, the years tick by, and of course, those of us with more miles on the clock know full well the phenomenon by which the older we get, the faster those years tick by. You know, things, you're sort of over the hump, and as you're going down the other side, it seems to be occurring faster and faster. What we do know is that there, and I'm teaching you to suck eggs here, there's considerable variation in biological aging. So biological aging is decline that is gradual and progressive, and it typically involves multiple organ systems. And the things that contribute to our biological aging are our, our genetic endowment, having chosen our parents wisely or less wisely, and our own biology. And of course, all of the exposures, both adverse and beneficial, to which we've been exposed as we've gone through the life course. And of course, for the NCDs, things like cardiovascular disease, hypertension, diabetes, chronic obstructive pulmonary disease, osteoporosis, you name it. By the time it's actually physically diagnosable, of course, there have been years and years and years of subclinical organ system decline building up to that point. The exception from our point of view, is oral conditions. We know that, for example, dental caries experience accumulates through life. When you look at the epidemiological data, the cohort study data, on average, it accumulates at about one surface a year at the same rate right through life, until we have the misfortune to enter a nursing home, after which it'll more than double. And if we have dementia at the same time, that will more than double as well. So it's quite interesting, the difference between cumulative conditions such as dental caries, incremental tooth loss, and periodontitis, and these other NCDs. So if we think about the Dunedin study, we've been following the same 1,073 there, 1,037 people through their lives since they were born in one calendar year, between 1 April 72 and 31 March 73. And we have assessed them periodically right up to midlife now. And we're planning now that the next assessment's at age 52, which will be in 2 years' time. Assessments have been done in the Dunedin study at each of these indicated ages, with the ones showing the mouths of when we've done dental assessments. And this remains really the world's best archive on human development, largely not only because of the wide range of information we've collected, but also because of the very high retention rate. Where are they now? They're not all in Dunedin. This is not a bunch of people who have lived in Dunedin all of their lives. They are spread out around the world and across Australia. Only about 1/3 of them are still in New Zealand, in Greater Dunedin. So wherever they are in the world, we bring them back to Dunedin for a full 1.5-day assessment. As you can imagine, it's very expensive, but it's really worth it. So bear with me here. This is what we thought we'd do is measure people's pace of aging. So we took 19 biomarkers that were measured from age 26 through to 45. We standardized each on the age 26 distribution, and then determined each person's rate of change for all 19 biomarkers and combined those into a single pace of aging variable. And we had dental markers for that as well here. So there's quite a lot here. There's cardiovascular biomarkers, metabolic ones, renal ones, immune system indicators, dental indicators, and pulmonary indicators. And we then, for this particular paper in Nature Aging, we were looking at indicators of neurological function, cognitive function, sensory motor capacity, and their own aging, and particularly the facial aging. And it was normally distributed, of course, because it's all standardized, but we've got people here, the average in the middle here, we've got the slow ages here and the fast ages here. So individual differences, as it says here, in rate of change in system integrity. And this is the distribution in our study members of the pace of aging. And these people at this end of the distribution are aging much faster than the others. The range was from 0.4 to 2.4. So the person or the people aging at the lowest rate were aging at 0.4 biological years per chronological year. You know, so they're the real Peter Pans, you know, people like Clive Wright, you know, Lockdoe. The others were aging at almost 2.5 times their chronological rate. And when we looked at them, excuse me, by midlife, by age 45, their brain structure was different. There was thinner cortical thickness and surface area, for example. There was early white matter deterioration. In terms of their brain function, they had poorer cognitive function, greater rate of cognitive decline. You know, this is by 45. Poorer sensory motor function. They had a slower gait speed and poorer balance. Looking at their facial aging was really interesting. We took facial photographs of the 10 participants with the youngest age, biological age, and the 10 with the oldest biological age. And so these are the 10, a composite of the 10 youngest women and the 10 old, you know, highest, fastest aging women. And you look at that difference for age 45, it's very marked. Down here, the same for the men. And people with that higher pace of aging, we got independent people outside the study to rate each of these photos of each of the study members, you know, to rate their chronological age. And the people with the higher pace of aging were also rated as having a higher facial age. So I'm going to come back to those findings. So if we think about conceptual issues and challenges in interpreting our gerodontological research findings. You know, older people haven't just appeared out of the ether. You know, the journey to old age, you take that journey through the life course, and there are all sorts of effects that go on that shape us as we age. There are the age effects that, you know, our gradual senescence once we've matured. There are period effects, so things that are going on out there at various times that affect everybody. And there are also cohort effects. So each generation, if you like, has its own cohort-specific effects that are happening to it. So, you know, I know that my cohort, the boomers, had the best music, for example. But, you know, if we look at them at any time during the life course, we will see those influences, you know, particularly in old age. And I think Ron Ettinger put it really well, you know, 30 years ago. Bit of old terminology here, elderly individuals. We don't like to use that term anymore. Older individuals are a complex combination and expression of their individual genetics, lifestyle, socialization, and environments, all of which affect their health beliefs and their health behavior. To understand an individual, you know, we have to look at the social, cultural, economic, and chronologically specific cohort experiences which have shaped their life. So what do we mean by that? Let's say we've done a national oral health survey in 2020, and we're looking at the older age group, and we're looking at our 100-year-olds, our 90-year-olds, our 80-year-olds, and our 70-year-olds. And you look at when they were born, there's quite a difference. There's 30 years between the oldest old and the youngest old, if you like. And so these people have been through different period effects and different cohort effects as they've been aging. So their aging has been against the background of these exposures. For example, you know, someone living in a fluoridated area, these 7-year-olds possibly have been exposed to community water fluoridation, certainly for the duration of the time that they've had their permanent dentition. Whereas up here, you know, it would be, say, 2/3 for the 100-year-olds. The introduction of fluoride toothpastes in about 1970, we all remember the ads with Mrs. Marsh and the chalk and the ink. Oh, it does get in. You know, it took me, it was years before I realized that that was an Australian ad. It was on high rotation over here in New Zealand. But, you know, knowing what we do about the topical effects of fluoride on incipient enamel lesions, you know, these constant exposures are very, very important and will shape the disease experience that we see in these people later in life. You know, the introduction of the air rotor in the middle of last century would have made dental care a heck of a lot more pleasant and efficient. And, you know, we all know about the fall in edentulalism in New Zealand and Australia, which was largely a social phenomenon rather than a disease-related phenomenon. Anyway, all of these things are happening, and people are aging through these different developments. And Ron Ettinger and Leo Makini, a couple of years ago, updated Ron's original paper on this, and they did it for, it's very much an American thing here, but this is quite an interesting slide to have a really close look at. It's in, oh, I can't remember where they published it, but if you Google Ettinger and Makini, you'll find it. Anyway, if we think about interpreting data on older people, you know, interpreting associations that we observe in studies of older people, we really have to be careful, because it is a real minefield, not just because of this sort of thing, but, you know, we've got to apply a degree of common sense as well, which sometimes I see missing from analyses. We've got a few periodontists on the line here. There's a great example here of overinterpretation of data. We've had almost 3 decades of periodontal disease being held responsible for, you name it, for just about everything. You name it, for just about everything. And Steve Offenbacher's group in North Carolina were very influential in this. And I had the great privilege 20 years ago now of going and working in North Carolina at Chapel Hill and being able to sit in on some of their weekly seminars. It was really interesting. If you look at the epidemiological data, the strength of the associations is not high, and some studies show associations, others don't. And one of the problems has been the failure to control for important confounders such as tobacco use, for example. But at the same time as this work was going on, there was a lot of work on the biological mechanisms behind it, you know, and this has been problematic in itself because it's led to what we call mechanistic bias. And this is where, if we can come up with a biological pathway, a putative theoretical biological pathway through which these associations can be explained, then we tend to be a little less rigorous maybe and critical in how we interpret the data because, oh, we've got a pathway for it, you know. Add to that problems in the discourse itself, so people using very, very lazy and inexact terminology linked to or related to, or saying that or something is increased in people with periodontal disease when it's not, it's actually higher in that sample, but they haven't observed it to increase. You know, we've had these problems of what I call terminological inexactitude. And these have actually added to the fog surrounding this. So we have to be careful. You know, the claims that periodontitis is a cause of all of these things, we're having to look at the flaws in that knowledge base. Most of it is cross-sectional. There's been very poor control of important confounders. The exposure measures have been poor and inconsistent, and they've tended to use things like the CPI or the average attachment loss. There's been overinterpretation of data and the aforementioned mechanistic bias. And there's also publication bias. Try and publish a null finding or something that goes against the prevailing orthodoxy, and you've got problems, you know. And the very latest of these specious sort of associations is that between tooth loss and cognitive function. And I want to spend a little time on this. So this is where it all began. This is data from a cohort study that was conducted with Japanese rest home residents back in, well, it was published in 2001. And this group of Japanese authors, it was an interesting and useful piece of work. They looked at, it was about 700 rest home residents, and they managed to follow up 37% of them. And they looked at their dentition status at baseline, and then 6 years later, they went back to them, and 37% was still around. And they measured their cognitive function, and then they had done it at baseline as well. So they knew that they were cognitively able at baseline. They then looked at reported the proportion with incident mental impairment, they called it. And you can see here that there is an ordinal hierarchy here of dentition status. So edentulous without dentures, edentulous with dentures, 1 to 19 teeth without a denture, 1 to 19 teeth with a denture, and 20 or more teeth. And you can see that other than, you know, with a little bit of a hiccup here, there is a kind of a gradient there where the lowest rate of incident mental impairment is seen among those with the greatest number of teeth. Now, of course, they didn't control for socioeconomic status, and that's it. The clear confounder that should be looked at with this. But also when they did do their multivariate analysis, the differences did not persist. Nevertheless, they did raise, when they were right in their discussion, they were considering the possible reasons for this gradient. And one of them, which they brought up semi-seriously, was that perhaps losing teeth contributes to cognitive decline. And, you know, it was seized upon in years which followed. And there were a lot of studies, a lot of Me Too studies jumped on the bandwagon. And then we ended up a few years later with a number of systematic reviews which have been published, all of which show an association between having, between cognitive function, poor cognitive function, and having missing teeth. Now, the caveats here, of course, are that they're cross-sectional studies. They've been using longitudinal language. Again, there's over-interpretation of data. There's publication bias, and there's also, you know, group think and operative here too. But if you think about it, I mean, if this was a thing, you would expect countries like New Zealand, Australia, Scotland, England to a lesser extent, which have historically had high rates of edentulism among relatively young adults, to have clear evidence of having poorer cognitive function among adults, particularly among older adults as well. But there's no evidence for that. Just thinking about it biologically, it's a challenge anyway, but let's have a think. These are the mechanisms that have been proposed for this. One is that maybe if you've got fewer teeth, you can't chew your food as well, so you're going to have a poorer diet, so you'll have poorer nutrition, and that somehow, if it's bad enough, will compromise your cognitive function. Not a lot of evidence, if any. The middle one is that you lose teeth, there are fewer contacts between the teeth, between the upper and lower jaw. So there's less somatosensory feedback through proprioception. So, or proprioceptive feedback. So on the principle of use it or lose it, maybe that means that you're going to have poorer cognitive function. Well, there's a big assumption there too, that maybe less somatosensory feedback leads to poorer cognitive function. But I just look at myself and Ratty, I see there, we're both two bald men, fine looking specimens, but we don't have any hair on our heads. So we have lost a heck of a lot of somatosensory feedback to our cortexes through that hair loss. And I don't know about you, Ratty, but I don't think it's affected my cognitive function. You know, I know the beer and the wine and all that has, but I don't think that, you know, the hair loss has. So, you know, it's a very strange mechanism, but this is actually the one that is favoured most by those who are doing work in this area. The final one is that periodontitis. Periodontitis has actually led to the missing teeth, and so of course through the common inflammatory pathways, etc., all the usual, the periodontitis is actually responsible for compromising the cognitive function. We know that, you know, periodontitis is a cause of missing teeth, but it's not the cause, not the most important cause. Dental caries continues to be the main cause of incremental tooth loss through life. So I got, you know, increasingly disturbed and perturbed through reading the literature and reading these papers where people were clearly misinterpreting what they were seeing. And so I had a sabbatical last year, in 2020, which was cut off by the pandemic. But during that time, I was able to work at home and collaborate with my co-author, Yoram Barak, from the Department of Psychological Medicine here in our med school. He's a psychogeriatrician. And we were able to work out what's going on, basically. And we published this in the Journal of Dental Research just over a year ago. So if you have a look at the various influences on cognitive function in old age. So this comes from a paper by Fratiglione et al. In Lancet Neurology a couple of years ago. If you have a look at all these environmental influences on, cognitive performance in old age, there's a lot of familiar things here that are familiar to us. If you look at risk factors for tooth loss, you'll see that there are a lot of the same ones here, of course, and there will be others. So it's interesting just to see these common risk factors. And of course, as we go through life, it's not just an all or nothing thing. These are, what we are at any stage during the life course is the net outcome of all of the various adverse and beneficial micro exposures that affect us as we're living our lives. Back to those pace of aging findings that I showed you earlier from the Dunedin study. You think about this, if we can detect this by midlife, this offers support for this big picture look at the influences on cognitive function throughout life. We have a substantial proportion of our cohort already who are not aging very well in terms of their brain function. And we know that there's continuity in cognitive function. This table is the one we had in our paper. I really enjoyed myself doing the background research for this, looking at all of these studies of cognitive function through life, and particularly the Scottish studies, the Lothian study and the Scottish Mental Health Survey, where Scotland in 1932 did cognitive tests on all of its 11-year-olds. And then decades and decades later, this guy called Ian Deary, who was at the University of Edinburgh, decided to track down those people and get them to do cognitive tests again. And he found quite a number of them and was able to show that those who were better cognitive performers as children had the better cognitive function in old age. And this has since been replicated in a number of other studies, clearly with not as long follow-up periods. We've even looked at it in the Dunedin study. So this is childhood IQ, the average child IQ between 7 and 13, because we measured it at 7, 9, 11, and 13 in the Dunedin study. So at this end, you have the less cognitively able children, and at this end, you have the more cognitively able children. And here we have IQ measured at age 38 in the same people. And you look at that, that's a very strong positive correlation, and a Pearson's R of 0.8 is strong. It's pretty good. And not only will these children with better cognitive function have better cognitive function as adults, they will also have greater cognitive reserve when they get to old age. So any age-associated cognitive decline will take longer for them to tip over into full-blown Alzheimer's than it would for somebody with who is less cognitively able. We know that our cognitive function influences our oral health. So the people who have poorer cognitive function in childhood, they embark on life course trajectories that mean that they have fewer opportunities, they have more adverse exposures than those of us who have better cognitive function in childhood and are able to get into jobs and living situations which are better for our health. Yeah. This inevitably involves greater tooth loss. But if you look at, I mean, you feel free to get onto CDOE and find this paper, because you'll see that it's not just tooth loss where we see these differences in oral health or oral disease. It's in periodontitis, it's in gingivitis, it's in self-care, it's in dental caries as well. So what I've done here is I've taken the tooth loss data from that table and I've charted them here for you. So here we have childhood IQ between 7 and 13. So this is the least cognitively able children. This is the most cognitively able. And you can see the prevalence here of one or more missing teeth by age 38. Half, and this is teeth missing due to caries, by the way, no other reason. So half, 1/3, a quarter, 1 in 5. If we make it a little more sort of stringent, our cutoff point, and we say, well, okay, 3 or more teeth missing due to caries by age 38. Again, you see the same gradient, although clearly the proportions are lower. I've lost my cursor. This is a problem with 3 screens. Here we go. So we're looking at it 1 in 4, 1 in 7, 1 in 12, 1 in 20. So how it works, we worked out how we see this association between missing teeth in old age and cognitive function. We know that we have this cognitive function continuity through life. We know that our cognitive function early in life selects us into particular life course trajectories. So, if you're a brighter kid, you end up going to university, you get a better job, you live in a better area, you're paid more, you're more able to take care of yourself, you're more able to understand health literature, etc. You have better health literacy, you're going to have better health, you're going to have a better life. We're all examples of that, We're going to lose fewer teeth along the way. People who have poorer cognitive function in childhood are going to lose more teeth along the way. And of course, if we compare adults at any age and look at the number of missing teeth they've got and their cognitive function, we're going to see an association. And if we do that in lots of different studies, and then we do a meta-analysis or a systematic review, we're going to confirm it. I have no problem with that. What I have the problem with is the notion that, or that people will interpret that as tooth loss leading to cognitive decline. Because what happens then? You have the situation we've got in Japan, let's name them, where people are proposing invasive prosthodontic interventions in the hope of staving off cognitive decline among patients. And that's not only reckless, it's crazy, but this is, this is what's at stake. We in our paper in the Journal of Dental Research, where we looked at this, I had already by that stage found 2 papers in the literature that were proposing this, neither of which came out of Japan, by the way. So at any age, we'll see an association. But if people continue to look at that association uncritically, we're going to end up with this unnecessary tide or epidemic of prosthodontic intervention. This is why when those of us working in gerodontology as a research field have a real responsibility to ethically and carefully and thoughtfully interpret our data, and to make sure that others do too. Here's a ridiculous example. My colleague Jonathan Broadbent used to go and went on these trips around the southern coast of Papua New Guinea on one of these, Christian ships that inflicted dentistry on the locals, and he came across this belief, they were very reluctant to have teeth out, and when he asked them why, he said, leads to, you'll become blind if you take teeth out, because they had actually noticed that among their older people, they had high rates of blindness, and they also had high rates of missing teeth, So this is the sort of level of intellectual reasoning that's been going on in the tooth loss and cognitive function field to date. Anyway, to step away from that, I just thought I'd show you, while we've still got time, a quick bit of work, info from some work that I did with a Chinese colleague, Songlin He, 2 or 3 years ago, where we thought it would be informative to, he arrived in Dunedin with Chinese National Survey data. I thought, whoa, let's go for it, and I had the New Zealand National Survey data. So we thought it would be informative to do some comparisons, because if you think about China and New Zealand, on the one hand, you've got a country, in the Confucian tradition, where the values of sort of obligation, reciprocity, and everything, we're all interrelated, and there's a lot of mutual responsibility and cooperation, although I hear that's being strained at the moment. In New Zealand, we're more in the Western tradition, every man for himself, and if that person over there is getting a benefit, then somebody's losing, so we can't have that. Let's all compete against each other and let the best man win, and it's usually the men. But these national characteristics, shape not only how we set up our health services, but also how we operate them, how care is delivered, and how those services are used, and also how people look after themselves and how they interpret their disease experience. So we thought we might be able to see some interesting differences. And here's another one of these tables. Don't you hate it when people put tables up on PowerPoint presentations? So we have a look here. Let's have a look. I've taken the 65 to 74-year-olds, and if we've got the red bars are China and the black bars are New Zealand. Big difference in the proportion dentate. Almost all of the Chinese older population is dentate, but only in that 65 to 74 age group, but only 7 out of 10 New Zealanders. And there were differences in respect of the traditional definition of a functional dentition there, the average number of teeth. And then when you look at overall accumulated caries experience, which is what the DMFT is, it's a cumulative measure of lifetime caries experience in the permanent dentition. You can see that it's about twice. And the New Zealand estimate is about twice that of the Chinese one. On the other hand, though, there's a greater prevalence of periodontitis among the Chinese than among the Kiwis, and also a greater prevalence, more extensive, I should say, bleeding on probing, so more gingivitis as well. And that's probably due in part to differences in smoking rates between the two countries as well. So I recommend you, if you're interested in this stuff, have a read of that paper too, because it raises a few interesting issues about how we interpret these data when we're making comparisons. And it sort of helps us guard against reductionist thinking about treating people as biological units, you know, which is what I was taught at dental school. You know, we were just biological machines, and the social context, the behavioral stuff, the wider exposures weren't even considered. So if we're thinking about comparing older people, what sort of differences between these two populations led to such stark differences between them, in terms of their, what sort of life course differences and exposures were taking place to produce these very, very marked differences by the time they're old. So when we're thinking about our oral epidata on older people, think about not only, gee, how do they differ now, but how did they get to this point? What were all of those little differences in exposures as they went through the life course? How did those result in those differences, those detectable differences? I hope you found this interesting and hopefully a bit controversial. There should be something there for everybody. Some of you will have thought about these issues before, and this will be old hat to you, but for others it might be quite confronting. Thanks to UQ and to Locke for the invitation. University of Otago and the Dunedin study have been very good to me. And one of the good things about work in my line of inquiry is that I get to work with a heck of a lot of clever people. And actually, I don't have Songlin Her's name there. I forgot to put it in. But these are some of the very clever people with whom I work. And I've got my Super Gold card here because this is what I got a month ago when I turned 65. So I'm now officially an old person. And this gets me on the buses for free, right when I don't need to get on a bus at the moment. But once I'm retired, I'll be on those buses. Thank you for listening. I'm happy to take any questions or whatever else you throw at me.
All right, so anyone has any question to Murray? Laurie?
Murray, thanks for a great presentation. I always love it when you talk about getting old, because the older you get, the more you get interested in this topic, I guess.
Absolutely.
I'm wondering if there are some implications of what you've been talking about, but going right back to the earliest parts of life, because now people are putting so much emphasis on, getting the right sort of, fish oils for children when they're growing up, and getting rid of the lead and all those things that are occurring in early development, which of course, when you think about some of the older cohorts, there were certainly exposures to some of those things and lacks of various things. So it'll be really interesting to see whether, as longevity increases, what happens in the last decades of life in terms of quality and health. Because one can almost imagine that, generations where greater access to, for example, sugar-containing foods and, the obesity epidemic and things like that might actually ripple through if you're looking at this data, 15, 20 years time. What do you think about that?
Oh, yeah, really interesting point, Laurie. That'll be fascinating. And to, by that time, we'll will have followed like the Dunedin study through to right into old age. And so we'll have that, but that's only one cohort, but we'll have data from other places. And yeah, it's really interesting. And it, raises the issue of the Barker hypothesis, the exposures in utero, et cetera, et cetera. And I don't know about wider health, but for me as an oral epidemiologist following a cohort through to midlife so far, one of the things that has become clearer, more and more apparent to me as these people of age is with these chronic cumulative conditions that the oral conditions are, where we end up becomes progressively more important relative to where we came from. Like, so I'm upwardly mobile. My dad had to leave school after primary school to help support the family. So, and it's so I'll never have as good health as somebody who grew up in a high SES household and ended up as high SES in adulthood. But I'm sort of low SES, high SES, being upwardly mobile. I will approach them, but I will never get to them, and for the unfortunates who were either low or downwardly mobile, as life goes on, things are going to get harder and harder and harder for them, so we will be diverging, and it's just something that I've noticed with our Dunedin study data is that, as the older they get, the more important, the more proximal exposures are.
I mean, there's certainly been some interesting work on what happened to children who grew up during periods of extreme privation during the Second World War in Europe, in the Netherlands and in places like that, and how that affected them across their entire lifespan. And today you wonder if, while there is greater awareness of neonatal health and infant health and in utero health, there's actually some declines that occurred during the teenage years. And there's also additional social pressures. And I'm talking about things like, home ownership, the cost of living, all those additional pressures, which one might argue could be greater now. So you've basically got a pendulum that's sort of oscillating backwards and forwards in terms of, net gain or maybe net loss. So it's going to be very interesting to see which way it ends up falling for individual people.
Exactly. And our generation, the boomers, as we're going through, we're pulling the ladder up after us, I paid next to nothing for my education, and I tell my students that and they can't believe it and they look appalled, and we put the cost onto them. It doesn't seem fair, does it?
Thanks,
Steve, can Steve jump in before you?
Steve, you're going first. Hi, Murray. That was fantastic. Really interesting stuff. We've done some work, not in oral health, but in sort of general overall health on that period cohort stuff you presented. And we've been working on models of actually using that to better estimate the future. And of course, what you find is the differences once you do the age period cohort models are greatest in the older age groups. This is what you've been saying essentially. And there was an economist back in the 1970s who said we should stop calling old age 65 plus, stop counting from years of birth. We should count it from years of expected death. Because you're failing to take account of the increased life expectancy. And when you use those models, those period cohort models, and you apply them to service planning, I mean, this just blows up the overestimate when you've got improving health and the underestimate when you've got declining health. And we're just going through the period now where we're entering old age. The first cohort who didn't experience things like the Depression, Second World War. The first cohort, they experienced a lot of the welfare state improvements, if you want, after the Second World War. So they're a very different group that's entering retirement now to what the last group of people who entered the retirement ages. And yet we continue to plan services based on this cross-sectional
Yeah.
utilization rate, without taking account of all of that. So I think to use your sort of modeling, or use your work for modeling future need, I think would be fantastic. I can certainly send you copies of the papers we've done and see if, you know, that's something we could extend into oral health.
That'd be cool. Yeah, I'd be very interested. Yeah, thanks for that. Yeah, it's funny, isn't it? As we're living longer now, dementia seems to be an epidemic. But you know, it's just that, you know, my grandparents and their parents, etc., didn't live that long, so it wasn't a problem. You know. Yeah, interesting times.
Thanks, Marty.
Thanks, Murray. Good to see you. And thanks for the talk. I would just, it's nothing to do with oral health, probably, but just curious about those slow ages and fast ages in that study that in the Nature Aging journal. And what is it about, what are the slow ages doing that they're not aging as fast? And what is it about the fast ages? And can we do anything about those that are aging fast?
Yeah. I mean, the obvious one is, I think, well, there are two obvious things. One is genetic, you know, makeup, the luck of the genetic draw. The second is cigarette smoking. You know, someone who has smoked all the way through is, you know, facially, health-wise, you know, in much worse shape than someone who hasn't, for example. And, you know, you can spot the smokers, you know, in middle age by, you know, how they look facially and you know, the tone of the skin, etc. You know, I started smoking at 16, working in the school holidays at the local brickworks, and couldn't give up. You know, I smoked for 7 years, and then by the time I was in third year at dental school, we did pathology, and by the end of that year, I was so frightened that I gave up smoking. But I'm really glad that I did, because otherwise I probably would have smoked right through life and probably wouldn't be here by now, you know, or, you know, would look even worse than this, you know. But yeah, it's things like that, and those exposures, you know, they need not be very different, because it's the small, subtle exposures that we see having their cumulative effect over time that make the big differences. For example, if you look in the Dunedin study and you look cross-sectionally, say at age 32, and you look at how clean the teeth are, and then you compare the dirty teeth people with the clean teeth people, and you look at how much accumulated disease they've had, there's not much of a difference. And we thought, that's counterintuitive. So my clever colleague, Jonathan Broadbent, characterized the plaque score trajectories through from the teens right through to you know, early middle age. And so we were able to identify three self-care trajectories. There was the people like us who started off here and got better as we got older. There's a bunch who who had reasonably clean teeth and didn't really change. And then there was about 15% of them who were on this who not only had poor oral hygiene early on, but they got worse as they went through life. And once we looked at, you know, accumulated dental disease by age 38, in those three groups, there were massive differences. You know, so it's the difference, it's a sum total of everything we do day by day. You know, my wife told me when I started hanging around her that I'd have to give up having sugar in my tea and coffee because they didn't have a sugar bowl at home. So I gave up. And I'm damn sure that has saved my dentition, you know, and kept probably 8 or 10 kilos off my frame by now, you know. And yet, if you looked at that on a day-by-day basis, there wouldn't be much difference between what I was exposed to then and if I had it and if I hadn't had it, you know. But accumulating over a lifetime through the life course, those differences, the effects of those minor subtle differences become magnified by time, you know. Did that answer the question? I went off on a tangent there.
No, it does. Thanks.
I suppose working in a cohort study gives you, and getting old too, gives you a very good sense of the life course and the way in which things develop over time. You know, one thing you realize too is that people's personalities don't really change over time. You know, an obnoxious kid is usually an obnoxious adult. You know, but look at ScoMo. You know, I bet he was an obnoxious kid. You know, oops, I'm electioneering. Sorry, I shouldn't have said that. Any other questions there?
Murray, I assume that you might have done it. Did you compare that oral health as a bit out of that curiosity, not in the topic, right? Compare oral health of those fast aging and slow aging. But if there's fast aging smoke a lot, tend to smoke, then let's make this a oral health problem.
Yeah. Well, you know, we had, you know, the perio and the caries experience as well as part of that pace of aging variable. So it's already in the exposure, if you like. Yeah, I imagine if we took them out of that and redid it and then looked at particularly their periodontal loss of attachment, we might see some really interesting differences.
Any questions? Another question to Murray? If that's a time. Any burning questions we can ask? Good. All right. Thanks, Murray. Thank you, everyone, for attending the talk today. Yeah.
Thanks for listening, everyone. Hope you found it interesting. See you.